Welcome to Module 3 of the ABC Compliance video series. In this module, we will explore the arcane world of anesthesia coding and the significance of the crosswalk table. Our goal here is not to make you anesthesia coders, but rather to help you appreciate the challenges our coders must deal with to code your charges. All ABC coders are certified by the AAPC, the American Association of Certified Coders. They do not make assumptions. They only code based on the information you provide on your anesthesia record. If a critical piece of information is missing and they have to research it or come back to you, and this delays the processing of the claim. There are 5 phases of an anesthetic: preparation, induction, maintenance, emergence, and recovery. The basic value covers all of these. The first step in the coding process is the review of the surgical procedure performed. Coders need to confirm that the description provides adequate detail so that they can determine both the surgical CPT code and the ASA code. Coders review the anesthesia record and, if applicable, the charge ticket carefully to ensure that they can correctly code the case. To help you understand and appreciate the coder's job, let's look at this from 5 perspectives. What's included in the basic value? The implications of the ASA crosswalk, specific examples of a one-to-many coding relationship between CPT and ASA, modifiers and conditional units, and documenting complex cases with multiple procedures. The anesthesia charge calculation can be thought of as a taximeter. You get in the cab, the driver clicks on the meter, and you already owe money. Additional modifier units are intended to reflect the degree of difficulty of the case from an anesthetic perspective. To this will be added time units for the time spent managing the case. Other services, such as those for invasive monitoring, nerve blocks, and ultrasonic guidance, will be billed separately. The basic value includes all the usual services performed by the anesthesia provider during the key phases of the anesthetic. This includes the preoperative assessment of the patient, the determination of the anesthesia plan, irrespective of where and how this is performed. It includes the placement of all non-invasive monitors and probes, and the administration of fluids, including blood products. It also includes all the necessary immediate postoperative management of the patient in the PACU or the ICU. The ASA Relative Value Guide ranks surgical procedures on a scale from 3 to 30. In cases where multiple surgical procedures are performed, the base value will reflect the procedure with the highest degree of difficulty. Each case is coded first for the surgical CPT code that describes what was done by the surgeon. It is essential that the surgical procedure description provided represents how the case was actually performed and not just how it was booked. Based on the determination of the surgical CPT code, an ASA code will be designated based on the ASA crosswalk. If information is missing or the description appears incomplete, coders will hold the case for additional research and a potential provider return. A unique challenge of anesthesia billing is the need to navigate between the CPT sequence and the more generic ASA codes. There are more than 8,000 surgical CPT codes, and only about 350 ASA codes. For the most part, there's a one-to-one relationship between CPT and ASA. But for more than 800 procedures, there's a one-to-many. In other words, one surgical procedure might map to multiple ASA codes. Sorting this out may require consideration of additional information, such as the surgical site, the anesthesia technique, or the position of the patient. The following are some of the most common examples of this issue, but there are others. There are many. A separate reference guide to a more comprehensive list is available upon request from the coding department. In every case but one, the procedural description provided should include the post-operative procedure details, including the surgical site, as well as any relevant anesthesia technique information, such as the use of an epidural. Note for these integumentary procedures, while in some cases the description provided may mention the surgical site, this is not always the case. In the examples on the slide, you will note that the debridement procedure codes do not include a site reference. This is critical, though, because ASA procedure codes involving the head or neck or the posterior trunk are worth 5 units versus 3 for the rest of the body. Another example. 2 of the most commonly used codes in anesthesia billing are ASA 790 and 840. 790 worth 7 units and 840 worth 6 units. These cover most procedures performed in the abdomen. The point of demarcation is the umbilicus. What coders look for is the phrase upper abdominal involvement for ASA code 790. While many procedures, such as a cholecystectomy, have an anatomical landmark that allows the coder to know the location, many, such as exploratory procedures, do not. Special attention should be paid to colon procedures because the ascending and descending colon falls in the lower abdomen, while the transverse colon is in the upper abdominal space. Arthroscopic procedures of the shoulder and knee fall into 2 categories. Diagnostic procedures are worth only 3 units, while surgical procedures are worth 4. It's critical that the procedure description includes the details of the surgical procedure performed, or a note saying diagnostic versus surgical. The use of a one-lung technique is a significant factor in the anesthetic management of a case and must be clearly noted. The use of a double lumen tube does not, in and of itself, justify billing for a one-lung anesthesia technique. The description of ASA code 00670 for spinal procedures has been revised within the past few years. It used to be that the most critical factor in determining the value of a spine case was whether or not hardware was used. As noted in the revised descriptor in the ASA Relative Value Guide, the critical factor is now the extent of the spinal surgery. An extensive procedure merits a value of 13. Extensive is defined as involving 3 or more paravertebral bodies or 2 or more interspaces. There are other examples of such crosswalk issues where one procedure may map to multiple ASA codes. ABC has developed a more complete reference list, which you are welcome to request from our compliance team. The anesthesia base value may be modified based on unusual patient or operative factors. Typically, these include the physical status of the patient's age, and whether the case was performed under emergency circumstances where a delay in treatment would risk life or limb. As an example, labors are typically not listed as emergencies. The unusual risks associated with labor and delivery are already factored into the base value. While most payers do not recognize these modifiers, they should be consistently documented. The ASA has recently provided some clarification for the use and documentation of physical status. Of primary concern from a billing perspective are physical status 3, 4, and 5. A patient with physical status 3 should have one or more medical conditions that may impact the course of the anesthetic. Physical status 4 involves more significant conditions that are a constant threat to life. Physical status 5 should be used for patients who are moribund. There's also physical status 6, which would be used for organ donors. While most cases involve one surgical procedure that can be easily mapped to one ASA code, many are considerably more complex. When there are multiple surgical procedures performed, then the provider must use his or her best judgment to provide the coder with information that will allow for the determination of the degree of difficulty of the case from an anesthetic perspective. If, for example, there is multiple trauma, contusions, and fractures, just pick one that best expresses the situation that must be kept in mind. There is one other special situation, and that has to do with cases that are partially cosmetic in nature. For these, it is necessary to note what procedure will be covered by insurance and what will be the responsibility of the patient. If you have questions about how these distinctions may apply to your practice, feel free to contact the ABC Coding Department. Thank you for participating in this ABC Compliance Program. We hope the information presented here is useful to you in understanding the requirements of compliant billing. We greatly value your comments and feedback on this program. For more information, feel free to write to jody.luck@anesthesiallc.com or even to call 619-249-9801. Please pass along any comments or questions you may have to the ABC Compliance Department at compliancehelp@anesthesiallc.com.